Anytime there is a suspicion of urinary tract infection, such as frequency, urgency, blood in the urine, or wet or sudden onset of daytime or nighttime wetting when they were prior dry, a urine infection should be checked for. And the way to test for this is with a urine culture. If the child is in diapers, a urinary catheterization is the appropriate way. If the child is potty trained, a midstream clean catch can be done. If the urine culture does show an infection, this child should be treated with antibiotics, and then an investigation of the cause of the infection should be undertaken.
What type of investigation are you talking about?
There are the standard tests, two tests. One is a sonogram, which is non-invasive and will check the size, position, size, and the anatomy of the kidneys. This will look for growth of the kidney, scarring, obstruction, or any stones that would be seen in the kidney. In addition, the bladder sonogram will be performed to see if the bladder size is normal and to check if the child can empty the bladder completely.
Sometimes when a kid pees, they backwash, and it's called reflux. Is that true?
Yes, we also test for something called vesico-ureteral reflux. Of the children under the age of 5 that have a urinary tract infection, approximately 1/3 of these children will have something called vesico-ureteral reflux. This means that urine, which is supposed to travel from the kidneys to the bladder, and then when the child voids out into the diaper or into the toilet bowl, there's supposed to be one-way valves preventing urine from refluxing back into the kidney. 1/3 of children that have urinary tract infections will reflux, meaning the valve in the bladder connecting the bladder back to the kidney is not working efficiently, and some urine can be refluxing back. If this does occur, there is an increased chance of kidney infections.
How do we handle that so we don't get problems with the kidneys down the road?
Well, the first thing to do is to test for the procedure, to test for the reflux. And the way one tests for this is called the VCUG. A catheter is placed into the urethra using a local anesthetic cream. The bladder is filled with a contrast or dye, and the child voids. As the child voids, an X-ray is taken, and we can see the flow of urine. If reflux is present, as I said, in 1/3 of these cases, we usually grade it from 1 to 5, according to the international grading system. Low grades of reflux can be treated with medication, and most will resolve with time. Higher grades may need surgical intervention with 2 types of surgery: the old-fashioned open surgery, however, there is a new procedure with minimally invasive procedure with an injection of a material into the bladder through a scope, which is a 15-minute non-cutting procedure and has an 80% success rate.
If a kid did have reflux, how long do you usually watch these kids carefully?
Usually, we would wait 1 or 2 years with antibiotic prophylaxis, which means a daily dose of a low amount of antibiotic to prevent infection while we wait for the reflux to resolve. We can wait 2 years as the average, but in some cases, if we're seeing improvement, we may wait even longer.
The prognosis of fall catheter usage is pretty good, isn't it?
Prognosis with reflux is excellent if we can keep the child infection-free with either antibiotics or surgery. We can protect the kidneys from damage, and the children usually do very, very well.